Hi, I'm Matt, a paramedic with ACT Ambulance Service. This educational video walks through my preparation, optimisation and team brief for a pre-hospital emergency anaesthesia, or PHEA, in a simulated adult polypharmacy overdose. Rather than limit myself to any one service's guidelines, I'm making the choices I think are best supported by the evidence throughout, as if I had access to whatever a well-resourced service could offer. My patient's an adult male found heavily altered at home, agents and timing of ingestion unknown. He is GCS 7 with eyes 1, voice 2, motor 4. He has a respiratory rate of 8, shallow and irregular, with snoring respirations, vomit in the oropharynx, and coarse crackles at the right base. His SATs are 86 to 88% on 15 litres via a non-rebreather. His heart rate is 128, blood pressure is 75/40, with cool peripheries and delayed capillary refill. We don't have information regarding the patient's temperature or BGL, so for now we'll just assume they are normal. So, he's not doing too well, but let's discuss whether PHEA is actually indicated. The simplest way that I think about it is to weigh up the benefits and risks of performing PHEA. The benefits are that PHEA will allow us to address his failure of airway protection, ventilation and oxygenation, but let's explore those a bit more. For airway protection, a GCS of 7 is obviously not ideal, but a common misconception is that it alone proves protective reflexes are absent, or that PHEA is automatically indicated. The stronger evidence is the vomit already in the oropharynx, his failure to clear it, and the crackles which should suggest aspiration may have already occurred. For ventilation, a rate of 8 and shallow won't clear CO2 on its own, regardless of what his oxygen saturation shows. This puts our patient at increased risk of acidosis, which unfortunately makes PHEA even more dangerous, but we'll get to that later. For oxygenation, he's severely hypoxic, despite maximum supply of passive oxygen. This means we're going to need active positive pressure ventilation. Now, despite these benefits, there are two major risks. First, this is what the literature calls a physiologically difficult airway, with hypotension and oxygenation failure already present and pH derangement likely given the hypoventilation and shock. His physiology may cause collapse on induction regardless of how easy the active tubing is. On top of that, the unknown ingestion means I can't assume a single toxidrome. This could be sodium channel blockade, sympathomimetic toxicity, sedative or hypnotic toxicity, or several together. So as you can imagine, this makes the situation a lot more dynamic. So that's the balance running through everything we do next. We may well decide the benefits of performing PHEA outweigh the risks, but the risks are still considerable. So if we think that the risk is justified, then we need to reduce that risk as much as we possibly can. We'll start with oxygenation and ventilation and then move on to perfusion. So our patient has vomit in the oropharynx, so I'll suction it now with electric suction ready and manual backup available as well. For positioning, I'm going to ramp him, but I'm also maintaining a sniffing position. So I'm aligning the ear with the sternal notch, with lower neck flexion and upper neck extension on top of that. If done properly, we get ramping's oxygenation and anti-regurgitation benefit without giving up the laryngoscopic view that the sniffing position optimizes. We're also going to increase our oxygen delivery because passive oxygen alone hasn't been enough. I'll insert an OPA and apply nasal prongs at 10 to 15 litres per minute beneath the mask, and have one clinician maintain a two-handed mask seal while the other controls the bag. I'll start at 5 centimetres of PEEP and titrate cautiously against his blood pressure. Higher PEEP in this profoundly shocked patient could reduce venous return further. Nasal oxygen stays in place during laryngoscopy too, provided it doesn't impair the mask seal. So hopefully this will help improve the hypoxia, but it will also provide pre-oxygenation for the PHEA procedure, and strangely enough, they're not the same thing. Pre-oxygenation aims to denitrogenate the lungs by replacing alveolar nitrogen with oxygen, maximising the oxygen reservoir and delaying further desaturation during the apneic phase. So next, I need to get my advanced airway equipment set up, so I'm going to let my ICP colleague Max here talk about how we can improve our patient's perfusion. Hi, I'm Max, the other ICP on this case. I'm going to be managing drugs, access and hemodynamics. First, I want 2 secure IV or IO lines. Then I need to think about what I'm going to give through them to improve his perfusion. Because so much is unknown, this patient's shock could be distributive, cardiogenic, hypovolemic, or obstructive, though the last one is much less likely. It could also be a mixed shock state, so we may need to treat more than one mechanism. I'll start by running up to 500 ml of normal saline as a cautious fluid challenge in case relative hypovolemia is at play, but I won't rely on saline alone. If perfusion remains critically inadequate as the fluid challenge runs, I'll need to step things up, but I need to be smart in how I do that.
Given his risk of arrhythmias and further hypotension, I'll target alpha-1 vasoconstriction with minimal beta-1 cardiac and beta-2 vasodilatory effects.
I'll use metaraminol as the initial vasopressor because it can be prepared quickly as a bolus while the noradrenaline infusion is being set up.
I'll start with 0.5 milligrams and reassess. If needed, I can repeat this dose every 2 to 5 minutes, but because the maximum effect is delayed, I won't increase the bolus dose for at least 10 minutes.
If his perfusion deteriorates while awaiting the full metaraminol response, I'll commence the noradrenaline infusion without delay and titrate it to the lowest rate that restores adequate perfusion. Induction itself might blunt whatever's currently compensating for its shock, and positive pressure ventilation could drop his venous return further on top of that. So realistically, I'm not expecting to get him fully stable. Just move things in the right direction before we induce. Now let's talk about the drugs used in PHEA. PHEA is more than just giving drugs and placing a tube. It includes induction, airway management, ongoing anesthesia and analgesia, paralysis where required, physiological monitoring, and ventilatory support. So making a choice for one thing may negatively impact others, and we need to take that into consideration. Our first decision, how to induce without unnecessarily worsening the shock. Ketamine is my first choice here as the lesser evil. This is mainly because it has analgesic properties already, meaning I can avoid giving an adjunctive opioid to our already hypotensive patient. Unfortunately, patients who already have a pre-induction shock index greater than 0.9 have a greater likelihood of exacerbated hypotension after ketamine. But as I said before, I think it's the lesser evil, and I'm banking on an opioid midazolam strategy being even less hemodynamically forgiving. I could reduce the ketamine dose, but this approach hasn't been adequately tested against standard dosing, and I don't want to risk inadequate anesthesia. Therefore, I'm using ketamine at 1 mg per kilogram, with vasoactive support already prepared. I'm going to apply the same rationale for ongoing post-intubation anesthesia and continue with ketamine rather than changing to a midazolam plus opioid infusion. Once he's anaesthetized, we'll need to provide adequate paralysis for intubation. The two most popular options are suxamethonium and rocuronium, but which should we use? The evidence doesn't clearly favour either drug once you account for modern rocuronium dosing. One difference is that rocuronium has a longer duration, but in this case, it won't undermine our failed airway plan because we are not relying on waking him or waiting for paralysis to wear off. Another difference is that suxamethonium has a broader contraindication profile, and I have no way of asking this patient for the medical history or allergies. So, in the absence of the information I need to rule out suxamethonium's contraindications, I'm going to defer to rocuronium at 1.2 milligrams per kilo. And that's it for IV drugs and hemodynamics. How are you going with your setup, Matt? Thanks, Max. So I've got all my gear set up now, so let's talk through the airway plan. Before committing to a device, I'll rapidly assess potential anatomical difficulties such as mouth opening, contamination, facial anatomy, neck movement, and the likelihood of effective mask or supraglottic ventilation. I'll also assess for logistical difficulties such as access, positioning, and lighting. Ideally, I want 360-degree access, with our kits laid out neatly and predictably, and more oxygen than we think we'll need because this whole thing is going to burn through gas fast. If I could have the patient on the stretcher, that would give better working height, but arranging it could cause harmful delay. For my equipment, I have suction ready. Plan A is intubation via video laryngoscopy. The device is checked, powered on, and prepared with the appropriate blade. Direct laryngoscopy and bougie are also prepared as the alternative technique. This patient has very little physiological reserve, so I'm capping tracheal intubation at 2 attempts, and a second attempt is only made if there's a meaningful change in strategy. As an example, if contamination obscures the camera, I'll withdraw, reoxygenate, apply continuous suction with salad, and switch to direct laryngoscopy rather than repeat the same failed setup I had on attempt number 1. 2 attempts is more conservative than the 3 attempts some international guidelines allows, but I think that this is justified given that multiple attempts are linked to significantly higher rates of post-intubation hypoxia, and our patient is already a physiological difficult airway. If intubation fails, plan B is a supraglottic airway. Given the same limited physiological reserve, I'll cap this at 2 attempts, with a meaningful change before the second. If that fails too, we'll return to 2-person BVM again while we prepare front of neck access, or FONA. If the BVM works, we reoxygenate and proceed to a controlled surgical airway. If it doesn't, that's a can't intubate, can't oxygenate situation, and we perform PHEA immediately because I don't want him to arrest. Waking this patient isn't realistic, and two-handed BVM isn't a practical transport arrangement. So successful BVM ventilation only changes the urgency of PHEA, not the plan. For the PHEA, I have a scalpel, bougie, and size 6 tube ready, with the tube tie or Thomas block in position. So now, I think we're ready to brief the team. Alright everyone, I'd like to run a short brief before we run the checklist to make sure we're all on the same page. We've done all that we can, but our patient still has significant respiratory compromise. I think that PHEA is indicated, but I think that it runs the additional risk of cardiovascular collapse on induction due to our patient's hypotension and unknown toxidrome. Do we all agree? Agreed. 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 So we've done what's feasible. We've ramped, we've suctioned, we've provided positive pressure ventilations, we've got the saline challenge running, we've given the metaraminol, we have the noradrenaline drawn up and ready to go as well. I think this is as stable as we're going to get. Does anyone have any suggestions of other interventions that we could possibly do before we go through the induction checklist? No. 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 Alright, let's assign roles. I'm going to be primary airway. Oscar, you're going to be my airway assistant. I'll need you to pass me equipment when I ask for it. And if we need to do any ELM, I will place the pressure where I want it. I'll guide your hand to where I need it. And I want you to hold it there until I say stop. Understood? I'll pass you equipment as you ask for it. And I'll apply ELM as you can show me and release it when you tell me to. Max, you'll be on drugs, access and hemodynamics. Drugs, access and hemodynamics. Jack, once we've finished this brief and we're ready to run the checklist, I'll take over the two-handed BVM and you can run the checklist for us. Alright, I'm ready to run the checklist when you are. So plan A is going to be intubation with a maximum of 2 attempts. Plan A there will be the video laryngoscopy. I also have the direct laryngoscopy with the bougie as the alternative if needed. If I'm going to be making 2 attempts, I want to make sure that we have a meaningful change in between the 2 attempts rather than just repeating the same process over again. In between any attempts, we need to reoxygenate. So Jack, I'm going to need you to get back on the two-handed BVM to make sure that we can reoxygenate as much as possible between these attempts. If intubation is unsuccessful, then we'll go to LMA, again, 2 attempts. If the LMAs are unsuccessful, then we're going to need to go down the front of the neck access pathway or PHEA. Again, we will return to the 2-person BVM. If that's effective, we'll take the time to prepare and make sure we're doing a controlled PHEA. If the two-handed BVM is ineffective, then that will be a can't intubate, can't oxygenate situation, and I will perform PHEA immediately. Confirmation of any of these attempts needs to come from multiple CO2 waveforms, not just a single one. Max, what's our PHEA medication plan? For induction, I have ketamine. For paralysis, I have rocuronium. And then for ongoing anesthesia, I have ketamine infusion. Alright, Jack, at the start of each attempt, I want you to start a 30-second timer and announce what our starting SpO2 is. Throughout the attempt, can you just continue telling me what the SpO2 is so I can tell if it's trending down? Once 30-second happens, I want you to let me know that that time has come. I can withdraw earlier if needed, and 30 seconds isn't a strict cutoff, but unless success is only moments away, then I'll withdraw. Confirmed. I'll start a 30-second timer, announce the SpO2 as our starting point, announce the trends, and let you know when 30 seconds is up. Alright, if he arrests, Jack, I want you to start CPR, and Oscar, I want you to put on the pads and run the first rhythm check. After that, Oscar, you'll take over CPR for the next full 2 minutes of CPR, and Jack, you'll take over team leading, which in our 4-clinician model here will involve keeping track of the rhythm checks and then running the rhythm check when it comes. Max will stay on drugs and access, I'll stay on the airway. Is there anything else that anyone wants to flag before we get into the checklist? Ready. 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 Alright, since there's no further concerns, Jack, I'm going to take over the two-handed BVM and you can run the formal PHEA checklist.